So liver transplant is the one evidence-based treatment that there is for primary sclerosing cholangitis. We've not really touched on treatment as such, but as all of you will know, there's also does it work, doesn't it work? But there aren't really any other treatments for PSC that are clearly alter the natural history of the disease and prevent disease progression. And I think the consensus is that URSO probably does not have that effect, although it may make people's liver numbers look better. So liver transplant then becomes extremely important, and liver transplant's a really good treatment for the right patient at the right time. So it's all about selecting patients and identifying the right people to have a transplant, and then transplanting them in a timely way. And there's a process to transplantation which begins with a doctor or a clinician identifying somebody as being somebody that might benefit from a liver transplant as being suitable. Then there's a process by which the patient is assessed for their liver disease. At the end of that assessment, there's a decision is taken by a multidisciplinary team about whether a transplant would be a good treatment, and that's generally taking into account what the indication is for the transplant, but also are there any contraindications? So are there any reasons why a liver transplant might not be a suitable treatment? So an example of that might be somebody who had severe heart disease or severe lung disease. They might need a liver transplant, but because of the other, we say comorbidities, but the other diseases that they have, a liver transplant might not be a suitable treatment. And at the end of that process, a decision is made as to whether somebody's suitable to go onto the transplant list. And then there's the period of waiting to the time of transplant. And that there's an average wait of around 9 to 12 months. And then obviously the period of post-transplant care after the transplant's been completed. So that's basically divided up into two sections. So the selection process is all of that happens up to the point of putting somebody onto the list. And then there's the issue of allocation, which is once you're on the list, who gets the liver? And that's a combination of two things really. Distribution, how the organs are shared around the country for patients with liver disease that are on the waiting list, and and what group of patients do you select to get the next liver. And it's a bit more complicated than that because, as I say, the assessment, it's a process, the assessment. So in most centres, about 3 out of 10 people that start a transplant workup do not get put onto the transplant list, and that might be for reasons that their disease isn't severe enough and there isn't a need for them to have a liver transplant. But it may be for the reasons that I've outlined, that they have other diseases that may have more of an impact on their survival than their liver disease. And unfortunately, while the numbers of transplants that are increasing in the UK, there still is an issue of lack of organs, such that in the most recent data, about 13% of patients are taken off the list because they deteriorate before a transplant can be offered, or they die while they're waiting for a liver transplant. But that's fallen from 17-18% a year or two ago, but it's still a very important issue in patients who are waiting for a liver transplant, and a very understandable fear for patients or anxiety for patients who are waiting for a liver transplant. And there's also the group of patients who get better while they're waiting for a transplant. So some diseases, liver disease, will fluctuate and will improve while they're on medical treatment to the point where a liver transplant is no longer required, and that's the best possible outcome because they get taken off the list and they continue to be followed up for their liver disease, but they no longer need a liver transplant. And in terms of outcomes, these are the sorts of outcomes that are generally cited for patients who've had a liver transplant. So 1 year survival of over 90%, 5 year survival of 80%, and a 10-year survival of around 60%. Now, it's important to bear in mind that the practice of transplant has changed over the last decade. So the outcomes that we're seeing from patients who were transplanted 10 years ago relate to the selection and practices of transplant at that time. So we'd be optimistic that the 10-year survival will improve over time. And there's certainly good evidence that the outcomes, the 1-year and the 5-year survivals, are increasing over time. So in terms of who is considered for a liver transplant, there's really 4 main categories. So these are patients with acute liver failure. So these are people that have previously been healthy and never had liver disease before and end up becoming sick quite suddenly and need a liver transplant. Chronic liver disease is by far the majority, is about 90% of patients that have a liver transplant, and that would, and so it tends to be patients with cirrhosis, and obviously PSC patients with cirrhosis fall into this category. Patients with liver tumours, and then the so-called variant syndromes are patients who may have liver disease but would not meet the standard minimal listing criteria that would allow them to go on to the transplant waiting list. So they may have maybe patients who have got significant symptoms but not very advanced liver disease. They may be people that don't have liver disease at all, so patients who have got polycystic livers who develop massive livers that very severely impact on their quality of life. Their liver's working normally, but the quality of life is terrible, and therefore we'll take them on for a transplant. And then there's a process by which, if somebody doesn't fall into any of those categories, the centre that is assessing that patient can write to all the other centres and say, we've got this patient, he's got this problem, we think he would benefit from, or he or she would benefit from a liver transplant. Do you accept this as a reasonable indication for liver transplant? And provided 4 out of the 7 UK transplant centres agree that it's appropriate to list that patient, the patient will be listed. But that's a very uncommon occurrence. It only happens about 10 or 12 times a year. But it does mean that it's not completely rigid, and we can look outside the kind of agreed criteria as to who should be considered for transplant. So in terms of PSC, there's 3 main categories that patients with PSC would fall into. This category, liver tumours, and then variant syndromes based on symptoms in the presence of less severe liver disease. So in terms of when we recommend a liver transplant as a patient should be having a liver transplant, what we think about is that patient's likelihood of survival. So what we know is that at 1 year, there's about a 90% chance that somebody will be alive after a liver transplant. So if somebody with chronic liver disease has an outlook that is worse than that, so we think it's more likely than 10% that they'll have a mortality of greater than 10% in the next year, that would be the time that we would consider putting them forward for a liver transplant. So it's all about trying to improve survival for people by offering them a transplant when the prognosis may be significantly worse if they do not have a liver transplant. But there's a really important clause that's built into the assessment process, which is utility, or probably a futility clause, which is that we shouldn't be putting patients forward for liver transplant if we don't anticipate that there's a greater than 50% chance that they'll be alive 5 years after they've had their liver transplant. So if you select somebody who has a 10% chance of being alive in a year, if you gave them a liver transplant, they might have a 20 or 30% chance of being alive at 1 year. That would be a very good outcome for that individual, because it would be significantly increasing the chances of that person being alive. But we also have a duty to look after the donor organs and try and given that we've got a restricted pool of donor organs, we've got a duty to try and get the best outcomes that we can achieve with the donor organs that we've got. So for that reason, the line is set at 50%. So we shouldn't be taking on people and listing them for transplant if we do not think we can reach that level of outcome. And obviously, if liver donors were unlimited, these sorts of arbitrary cut-offs would not be necessary. But that's not the situation we find ourselves in. So in terms of how we work out the prognosis for an individual patient, we use a score called the UKELD score, and it's really just a measure of the liver function, or a measure of prognosis based on objective parameters. So these are parameters that can be produced in any hospital or any lab around the country. So bilirubin and INR, in people that have liver disease, obviously they become jaundice. In patients with liver disease who've got liver failure, the INR rises. So that's the blood clotting is impaired, and the measure of the blood clotting is the INR. So in people who are jaundice with a high INR, that leads to a higher UKELD score. Patients with advanced liver disease who are at risk of dying tend to have worse kidney function. That's what the creatinine measures. So a high creatinine is associated with a worse outcome in liver disease. And patients with a low sodium tend to have a worse outcome if they've got liver disease. So there's a complex logarithmic equation that is then conducted, and we come up with a UKELD score. And hopefully you can see that, but the cutoff for going on to the liver transplant waiting list is 49. And the rationale for that is that if you look at the outlook of patients who are on the transplant waiting list, this data is from patients that were on the transplant waiting list, but if you take people that have got UKELDs that are less than 49, the outlook is the survival at 1 year is almost 100%. So you are, by offering those patients a transplant, there's a risk that you're going to shorten their lives rather than extend it. Why would, if you anticipate there's a 95% chance of being alive in a year's time, why would you offer somebody a liver transplant and say that there's a 90% chance of you being alive in 1 year's time? So, so while this isn't built around a UKELD of 49, what you can see is that in this sort of range, and that's probably the sort of range where most patients in the UK are when they have a transplant performed, the 1 year survival is less than 90%. So there's 90% there, and there's 1 year there. So the 1 year survival is less than 90%. Hence, we go on and list them for a liver transplant. And so by far the majority of patients that go onto the transplant waiting list have got chronic liver disease with an elevated UKELD, and that's how they make their way onto the transplant waiting list. There's also the subset of patients with liver cancers, and that the one liver cancer that is a common indication for liver transplantation is hepatocellular carcinoma, and that can clearly arise as a complication in patients with PSC. But they're quite tight criteria. It's not all comers. Initially, when transplantation became available, it seemed obvious the group of patients that would benefit from a liver transplant would be patients with liver cancer, hepatocellular carcinoma. Lots of patients with liver cancer were transplanted. The outcomes were terrible. And then it was only retrospectively that criteria were defined whereby if patients are within those criteria, there's a low likelihood of the cancer recurring after a transplant. So there's about a 10 to 20% chance of tumor recurrence in people that fall into these criteria.
Can I ask a quick question?
Yeah, certainly.
If there are guidelines for transplantation if you've got a liver cancer, even if they are quite stringent, why does the same not apply to cholangiocarcinoma, which is bile duct cancer, when the bile ducts are removed in a transplantation process?
Because all of the evidence using it was the same process for cholangiocarcinoma that I described for HCC, where people with very extensive disease were transplanted, but also people with quite localized disease, intrahepatic disease and extrahepatic disease were transplanted. But in all the series that were published up until the most recent series that we were talking about from North America, the survival is 10, 20% at 5 years. So the problem is the outcomes in an unselected population are very poor. So it does come to it does become an issue of selecting within the cholangiocarcinoma group a very tight group of a tight set of criteria that might allow you to take them forward to transplant.
So in the same way that you went back retrospectively and looked at cancer
yeah.
and came up with a narrow guideline, the same thing could happen in this country with cholangiocarcinoma, just at the moment.
That's right. So I don't think that I would predict that in time we will, selected patients with cholangiocarcinoma may become candidates. But as I say, we've been in a very dark place in terms of donor rates in the UK. And so with quite a high waiting list mortality. And that's been the main argument against expanding criteria.
But that goes against the quality of life argument that if you have got a subset of patients who could have a better quality of life, like having a transplant. What you're saying there is that the people who already can be put on the list to survive are more important than people who could have a good outcome if we allow them on the list.
But it's about making the argument about what those selected groups are and what those selected criteria are. And those attempts have been made, fair to say, not in the last 2 or 3 years to get cholangiocarcinoma as an accepted indication. And we've been unsuccessful in winning those arguments. But I think now that the waiting list mortality has fallen to the lowest level it's been for a long, well, the lowest I'm aware that it has been, it may be that we'd be in a better position to win that argument.
Thank you. Sorry for interrupting.
No, that's fine. Pleasure. So in terms of the variant syndromes, as I say, these are people that don't have decompensated liver disease. This is based on patients who have symptoms, and as Steve showed in the slide, and as you all are aware from the questionnaire that you completed, the two groups that are particularly relevant to PSC are pruritus and recurrent cholangitis. So we're allowed to list patients with intractable pruritus, so that's just persistent and untreatable pruritus as a consequence of cholestatic liver disease, where we've failed with other mechanisms to control the symptom. So it's up to individual centres to work through. There's European guidelines on cholestatic liver disease and the management of associated symptoms. And once we've exhausted the treatment options, if somebody continues to have itch, we would consider listing them for a liver transplant. And the other indication that's relevant to PSC is clearly recurrent bouts of cholangitis, because somebody may have absolutely, pretty well normal liver function, their bilirubin might be normal, but they may be on continuous antibiotics by a line, and continuing, despite antibiotics, to have recurrent episodes of infection that may require hospitalization. And again, centres are allowed to list patients for that indication. So the two, we've covered most of this, and I was just going to talk to this, but we've covered cholangiocarcinoma currently is not an indication in the UK. And the other symptom that is not accepted as a variant syndrome is lethargy. Now, the point to make about that is lethargy in somebody who's got cirrhosis that's decompensated with a high UKELD is clearly, they're accepted onto the list. But what we're saying is that if somebody has lethargy but good liver function, the evidence is that the lethargy does not improve with a liver transplant. So undertaking a liver transplant in somebody with good liver function just for the symptom of fatigue or lethargy is putting someone at additional risk without the prospect of benefit. So currently, lethargy remains lethargy alone remains a contraindication to transplantation. So this is what I was talking about in terms of the number of donors. So the number of donors has been increasing over the last 10 years. So this is since 2004, 2005. Number of donors in blue, transplants in yellow, and the number of people that are on the waiting list. So while the number of donors and transplants has been increasing, liver transplants has been increasing in the UK, unfortunately, that's been associated with an increase in the number of patients that are waiting for a liver transplant. And last year, up until April of this year, while we transplanted the largest number of patients with a liver at 880, we also listed the largest number of patients for a liver transplant, and that the total number of patients that were listed in 13-14 was about 1,200 patients. So there's still a shortage of donor organs for the number of patients based on the current accepted indications for liver transplantation.
Can I ask a question?
Certainly.
Has it gone up because you used to not be able to accept many cardiac donors?
Yeah.
Is that the main reason that it's gone up, or is it not that?
Yeah, so that wasn't something I was specifically going to go into on this in the talk, so I don't have any slides for that. But yeah, the types of donors that we've got are sort of three types of donors. There's deceased donors and live donors, and within the deceased donors there are donors that have brainstem death, and there's donors that have cardiac death. And the donors that you're referring to, the difference between those two types of deceased donors. So one of the ways that UK Transplant tried to get out of a very difficult situation with low donor numbers was to use more DCD organs. But in fact, last year, for the first time, and I think it's probably as a consequence of efforts from NHSBT, the largest increase was in brain death donors, so the better quality donors. So it's a combination of the two, but in fact, the brain death donors are having increased more than the DCD, the cardiac donors, last year and certainly this year. All right. Yeah. Live donors numbers are pretty small. So I think out of that 880, it's about 60 live donors in total. And many of those live donors are what we call domino donors, which is that somebody with a metabolic disorder who might have an indication for a liver transplant because their liver doesn't do an important job manufacturing some kind of protein. And they may need a liver transplant. We give them a transplant, and then we take the liver from them and give it to somebody else who may have cancer or some other condition where the chance of them getting a transplant may be reduced. And while they've now got a liver that's got some kind of abnormality, often the abnormalities that liver has don't cause any problems for 20 or 30 years. So it's a reasonable way to go about it. So I think in terms of live donor, where the donor is a friend or a relative, is about 30 per year. And in fact, the majority of them are pediatric.
Specifically for PSC, how many live donors? Because again, in the US, it's pretty common to have many, not common, but like
I couldn't tell you how many live donors for PSC out of these figures. I mean, there are challenges of live donor transplant in patients with PSC, particularly patients who've had previous abdominal surgery, so patients, say, with Crohn's disease or have had a previous colectomy, because it makes the operation much more challenging and therefore makes the live donor operation more challenging as well. But as a centre, and I think most other centres behave in the same way, that when we assess patients, we'll make sure that we give every person that we assess information about live donors and the opportunity for them then to discuss it with their family and for any live donors to come forward. So it's really important to individualize the issue of live donor, because there's some people that live donor transplant isn't suitable for, but there are many people that it is. But best people come forward and then we can start making those decisions. But the truth is the uptake by the number of people that come forward, only about 10-20%, maybe as high as 30% will actually get to the point where they will be able to donate. And there are many reasons that potential donors fall by the wayside, mostly because they turn out not to be suitable, because the donor obviously has to be very healthy and we have to be able to expect that the donor would get through an operation to donate a significant chunk of their liver with a good outlook, and sometimes that's not the case. Okay.
I think that's where maybe we fall down a bit, because when I was at King's, I was told that live donor was not an option. It was not even discussed with me, whereas when I was here, it was often thoroughly looked into. So I think maybe you're not getting the same level all over, you know what I mean?
I think NHS England, who fund transplant centres, are quite concerned at the moment about live donor liver transplant, as in, is it something that's going to take off in the UK? One of the reasons that it hasn't taken off is because of the risks. I mean, the quoted risk to the donor is about 1 in 200 risk of mortality. So that's significant. It's not much different to the risks of a kidney donor, say. So it's the stakes are quite high, and you know, I can't comment for how other centres go about introducing the idea of live donor, but we certainly try and promote it as an option. We've got a surgeon who's very experienced in live donor, and we certainly try and give all our patients the option, but that translates only into 1 or 2 live donor transplants per year. So there's a lot of work without generating that many transplants. So that's the number of transplants, the number of patients that are waiting. And sorry.
What's being done to increase the supply going forward?
So there's so NHSBT, so NHS Blood and Transplant, are responsible for the governance of transplantation. They're also responsible for the whole donor side of the process, there was, the whole thing started in around 2008 when there was a real issue relating to how low the donor rates were in the UK. And there were some people that were wanting to, you know about opt-in and opt-out. So you'd have to say, no, I don't want to donate my organs, rather than go and register as an organ donor. And that was one of the debates that was going on at that time. But a review that was set up, and a lady called Elizabeth Buggins, who was I think the chief executive of the Midlands Strategic Health Authority, chaired that, and they came up with something like 13 recommendations. And what the key elements of that were professionalising the donor process. So what now happens is every hospital has got a SNOD, they're called, specialist nurse in organ donation, and it's their responsibility to try and educate within the hospital about what groups of patients may be suitable organ donors, and it's really just I suppose the interaction between them and the intensive care team. And also there's been a lot of work taking place with intensive care to try and get people to think about organ donation. So if you look, there's various points at which organ donors fall out, but historically one of the reasons, quite common reasons, was it wasn't ever being considered. And families, it's a very difficult time. Somebody's in intensive care, they're on a life support machine, they're not going to survive. Are you going to approach them about becoming an organ donor? And there's been a fair amount of stigma attached to that. So a lot of that's been addressed in the last few years, and it's made a substantial difference. But that was a 5-year plan from 2008, and now they've just produced a further plan taking them to 2020.
I don't know if I read the draft copy on the previous slide, but was it that there were more people donating organs than transplants carried out?
So that's so the point there is that not every donor, organ donor, is suitable to donate their liver, say. So if you've got a donor who's got cirrhosis, say, they could give their kidneys, but they couldn't give their liver. So you know, unfortunately, some donors, donor livers aren't suitable for liver transplant. Okay, so this is the, in terms of the indications for liver transplant. So this was 1 year, 12, 13. And you can see that PSC is in green here, and it varies from centre to centre, but the average is around 9%. So it's about 9%, 10% of patients who are transplanted in the UK are transplanted with PSC as an indication. And this is the outcome of patients once they go on the list. After they go on the list at 6 months, about half of them are transplanted. At the end of a year, about 2/3 of them will have been transplanted, and at the end of 2 years, almost 3/4 of them will have been transplanted. As I say, unfortunately, about 13% of patients will have passed away. 9% of patients will be removed because they're too well, and about 6% of patients will be waiting 2 years for their liver transplant and continuing to wait. So once patients are put on the list, this is the sort of outcome that is experienced. And the issue that arises is who on the list do you give a donor organ to? And there's various ways of potentially allocating organs. So you can pick, you can decide that you give the organ based on need. You can give it to the person who is always sickest, and that seems like a very logical way of doing it, whereby you will always take the person who's got the highest risk of dying. But the downside of that is that comes back to a point I made earlier, that some of the sickest are also the least likely to survive. So if you always transplant the sickest, the outcomes after transplant will deteriorate. And that was a system that the Germans moved to about 3 years ago, and their 1 year survival after transplant fell from 90+% to about 70%. So it had a massive detrimental impact on the outcomes after transplant if you always just take the sickest patient. The alternative approach is pick the person who you think is going to do best after the liver transplant. And there's some logic in that if you're only caring about the outcome of the donor organ. But the problem is you're going to be standing back and watch the sickest people succumb waiting on the liver transplant list. And given that the intention of liver transplant is to try and improve survival from liver disease, it doesn't seem logical. And then the third option is transplant benefit. So what you do is you think about what that individual survival might be without a liver transplant, what their survival might be with a liver transplant, and the gap, when that gap is biggest, you transplant those patients. And I think in reality, most centres currently are allocating organs on the basis of need and on the basis of transplant benefit. But it's quite difficult to show that transparently. So these are the outcomes. This is what I was saying about in recent times the outcomes are improving. So the pink line here is 2000, and the green line is the last cohort to 2012. So there's substantial improvements of 5-6% increase in survival at the end of 1 year. And the outcomes are measured in all the transplant centres and compared in all the transplant centres, and the outcomes are, there's no centre that provides statistically significantly different outcomes after transplant in the UK. So regardless of where you're seen or where you're listed or where you're transplanted, the outcomes after your transplant aren't different. And there's also, if you look at from the period that the person goes onto the waiting list, rather than from the point that they have a transplant. So this is survival curves from the point of going onto the transplant list. All of the centres have the same outcome. So that means that it means that there isn't a benefit from shopping around between centres. The system may have its faults, but the patients will have roughly the same outcome if they're listed in Newcastle or they're listed in Birmingham. So I think there's evidence of that the centres are functioning to the same guidelines, but also achieving the same outcomes. So thanks.
Obviously, most of your data is sort of 10 years. Do you have any data that spreads out to sort of like 30 years for the younger PSCers who may get transplanted? You know, if you've got a child, for example, you know, they're obviously trending downwards. Is it just going to continue downwards, or?
We don't have that data as such. Also, if you're thinking about transplants from 30 years ago, you know, that transplant was pretty well in its infancy at that stage. I think the longest surviving patient after a transplant in the UK at the moment is 40 years. But that's because very few patients in the early days survived even 90 days after their liver transplant. So the actual, it's only going to be in 10, 20 years that we're actually going to know how to answer that question. I'll try and say something about it, but it's a really important point, and we can't answer.
Is
Hi.
there a maximum age at which you would do a liver transplant? Or is everybody just treated on their own merits, irrespective of age?
I missed that question a wee bit, but do we take age into account?
Yeah, is there a maximum age?
There isn't a maximum age. There's clear evidence that the older someone is at the time that they have their liver transplant, the worse the outcome is. But it's obviously a select group of patients, of older patients, that get listed. So the patients that do get listed that are older still meet the 50% 5-year survival. So I think the way to think of it is that if you were looking at listing patients that were 20 or 30 years of age, then maybe 90 or 95 out of 100 of them might get onto the transplant waiting list. But if you look at somebody who's 65 or 100 people with, who are 65, maybe only 20% of them might be suitable, or 15% of them might be suitable to get through what is a very big operation with very significant risks associated with it. But once people are on the list, we don't treat people differently based on what age they are. It's all about what outcome we think we can achieve for them.
Are the survival trends any different depending on the sort of subset of liver disease that people have?
Yeah, I think we're, so I'll go on to talk about that just now. I mean, one of the questions, the obvious questions is what do those outcomes sort of mean? How do they relate to what my life expectancy might have been if I hadn't had a liver transplant? That's a very difficult question to answer, because people are having a liver transplant for a reason. So, you know, if you look at the survival curves for the liver disease, they're dropping off without having a transplant. So we're not expecting with a liver transplant that we can return people to normal health and life expectancy, but what we are aiming to do is to substantially improve the outlook for that individual compared to not having a transplant at all. So in terms of, this is data from the UK, it was published in the late 2000s, and if you look at, it was a very large cohort of UK patients that were transplanted, that there was an average and expected, calculated shortening of life expectancy in people who had a liver transplant by 7.7 years. So in the cohort of patients, the average life expectancy was just under 22 years. And if you took healthy general population based on the same, a control population based on the same demographics, you would expect them to live 29 years. So that would be the population as a whole. But if you look at it by diseases specifically, what you see is there are certain groups of patients here who have the worst prognosis and the least life expectancy after liver transplant. So this is likely to change now with the advent of new treatments for hepatitis C, where we can offer cure in 95, 98% of patients. But certainly at this time in the late 2000s, the life expectancy for patients transplanted for hepatitis C was calculated to be only 12 years. For patients who had hepatocellular carcinoma, it was even less. But if you look at where PSC sits and where primary biliary cirrhosis sits, the outcomes are very favourable. So the UK population you expect is an average survival of 29 years, and that a survival of just under 27 years was achieved in that cohort. So I think what that tells us is that PSC is an excellent indication for liver transplantation. That the downside of PSC as an indication for transplantation is that of recurrent disease. So this is data, UK data from James Newburger. But aside from hepatitis C, which we've said is certainly historically has been a massive problem and a very high recurrence rate because most patients transplanted for hepatitis C have the virus and the virus infects the liver. With PSC, behind hepatitis C, PSC is the commonest disease that recurs after transplantation. It recurs after in approximately a third of patients, and about a quarter of these patients will end up losing the transplanted liver because of disease recurrence. And that's
quarter of the people where PSC, just answer
I think it's a quarter of the 37. Yeah, that's right. So what that translates to is, and this is data followed out to about 15 years, PSC is in the blue line here, but about 15% of patients transplanted for PSC will lose that organ, that liver, at 15 years. So it is a significant issue in terms of disease recurrence, but clearly in those situations, if people develop recurrent disease, that would be an indication for us to reconsider that individual for a liver transplant. Now, currently, there's no limit to the number of transplants an individual can have. It's clear that once people have had 2 transplants, the survival after a third transplant is just touching the 50% 5-year survival. But so there's certainly no reason that would prevent us from reconsidering someone for a second transplant. It may be in the future that we will not be allowed to list patients for 3rd or 4 grafts, but at the moment that isn't the case. Okay, so just to sort of summarize what I've said, so there's national criteria that all centres work to for when we look at patients and consider them for a liver transplant. And there's good evidence that centres are listing patients at roughly the same stage of disease, transplanting patients at roughly the same stage of disease. Once patients are listed, the average waiting time is around 9 to 12 months. And unfortunately, there's this mortality of around 13% that we're aware of. PSC accounts for approximately 10% of patients that are on the transplant waiting list. It's an excellent indication in that excellent outcomes are achieved. Excellent outcomes are seen after liver transplant, and PSC is associated with excellent survival. So overall, the outcomes after transplant are good. PSC has excellent outcomes, but there is the issue of disease recurrence, and about 15% of patients may lose their grafts after about 15 years. So, thank you.